everyone for being here today. I'm Barrett Levesque. Can you hear me? Is this microphone working? Very good. So I'm a gastroenterologist here at University of California, San Diego, and a researcher in inflammatory bowel disease. I'll be talking today about updates in treatments for inflammatory bowel disease, but more along the lines of what are the general treatment strategies we're using right now to treat inflammatory bowel disease. And I think you can take many different tactics to get to the same goal, and we'll be substituting, as time goes by here, new medications in for the old ones, I think, as we're always looking for any kind of medication that has more efficacy and, of course, less side effects than current medicines we have, and generally work in different ways to meet these same goals. A question that often comes up is who gets this top-down therapy and who gets step-up therapy, or who gets step-up versus step-down. And I think that paradigm will be something that will be interesting for you to see, because it's what a lot of your clinicians are thinking about when they're thinking about how best to treat inflammatory bowel disease in either yourself or a family member or a friend, and that's helpful. So the story goes that once upon a time, there were only a few treatments for inflammatory bowel disease, and this really wasn't that long ago, only perhaps 3 decades ago. And basically, in the 1940s, corticosteroids were put on the map, the late 1940s, early 1950s, by 2 British clinicians, Truelove and Witt. And in the first randomized trial in inflammatory bowel disease, corticosteroids were studied in ulcerative colitis and shown to be effective at inducing a remission. And from that, therapy was considered to be effective for colitis and then translated into treatment for Crohn's disease as well. So the foundation of treatment in inflammatory bowel disease really starts with corticosteroids. Now, what does this mean? Well, steroids are probably one of the riskiest medicines that you'll ever see from your physician who's treating you or your family. We know that steroids have multiple side effects from diabetes, glaucoma, thin bones, infection risk, but are probably one of the easiest medicines to prescribe. It's a medicine you see a lot of. It's treated. One treats poison ivy with it for a week or two, so what could be wrong with it? But we know that corticosteroids in the long term have substantial side effects. And we also know that they're not effective even from this earliest trial in inflammatory bowel disease for the long-term treatment of colitis. Really, although someone might feel better, more often than not, the ongoing inflammation that we're not seeing, that if you saw on your leg and you had a big ulcerated rash, you'd say, gosh, this isn't getting better, but maybe it feels a little better, is usually still there. And steroids then became this foundation of treatment because it helped symptoms. And from that, symptoms actually became a primary endpoint for a lot of the clinical trials that have been done in inflammatory bowel disease to date. Often we're asking, does a person feel better? And if a person feels better on a medication, well, then maybe that's the right medicine to give them. And that's where we were. And the fact was that many patients went on to have surgery. For Crohn's disease, about half of patients were having surgery in about 10 years' time. So half of patients were losing part of their intestine despite feeling better. And many patients with this consequence were having problems. Patients ended up with problems with surgery that happened repeatedly over time, or, for example, one large surgery, patients would have what's called bile salt diarrhea, or even more, if more extensive surgery was done, fat malabsorption or short gut syndrome, and difficulty even absorbing nutrients and losing weight. And so surgery led to more surgery, and we were at a time point really where this pyramid was basically 2 options. So one day, and this happened over a few decades, additional medications were found. And from that, a new paradigm occurred. And in this new paradigm, this new treatment algorithm or strategy, because there was a previous idea of, well, we start with steroids and then we add something on, and we add something on again if that's not working, there became this idea of a therapeutic pyramid, or the ability to either step up it or step down it, meaning go up the pyramid from bottom to up or top to bottom. And so where we see medications now falling into place are separate for Crohn's and ulcerative colitis, but I think we can lump them the two together here just for the purposes of the illustration. So 5-ASA, what's that? No one says I'm taking 5-ASA. Many people don't. So that's mesalamine products. So mesalamine products come in many different forms, sizes, formulations. probably one of the biggest goals right now is to find a medicine. We don't have to take it 12 times a day. You can take it once. I do, well, 12 pills a day, maybe take 1 to 4. You don't have to take something 3 times or 4 times a day. Maybe you can take it just at breakfast, just at dinner, or maybe at most twice a day. So 5-ASA means mesalamine medicines, and you'll see those. You'll see a variety of delivery formulations. You'll see the classic sulfasalazine, which was one of the original, well, the original 5-aminosalicylate formulation for ulcerative colitis or even Crohn's colitis. You see antibiotics, and gosh, what do you use these for in colitis? Is this an infection? Well, we often use these for patients with fistulizing or abscess-forming disease. This can help cool down the infection as the other medicines are taking over. Perhaps there's a small role sometimes for after a surgery for antibiotics that maybe is a little bit better than placebo in some trials.